practice in the UK versus what's done elsewhere. And just to put things into context, functional constipations account for about 30% of children, certainly in the Western world. And whereas Hirschsprung disease has a prevalence much, much lower than that. So when rectal biopsy became the gold standard for definitive diagnosis in the 1950s, I wonder what our positive pickup rate was. And if you look at the data from Leeds and from Southampton, it was consistently around about 12% pickup rate. So that's clearly a reflection of our patient selection for this modality being slightly deficient. And I wanted to know why. And I think part of the problem is that when a child presents as the Hirschsprung disease, is a broad spectrum, from a neonate with distensions, with radiological evidence, to a sort of young child who's got very severe constipations. And it's really hard to say within this spectrum who needs a rectal biopsy. So even the indication as a starter is already a difficulty for all of us. In the UK, we primarily do two types of rectal biopsy. One is the suction rectal biopsy, which according to Professor Puri's data on the meta-analysis is very safe, but has got around about 10% inadequate biopsy rate. This is very slightly different from our experience, I must say. The data from Chelsea and Westminster will be about 4% inadequate biopsy rate. But nonetheless, it is what in the literature is. But we also do open rectal biopsy, particularly in older children, to get a definitive diagnosis. But the problem is that it does involve a general anesthesia and therefore more resource intensive. So this is, for those of you that may not be familiar, is the Thames barrier on the east side of London of River Thames. And the barrier is a floodgate, if you like. It's to stop floods from coming in from the North Sea into London. And it was built about 4 decades ago, and it has prevented London from being swarmed and flooded with water. And I think it is with this concept in mind that we have the NICE guideline, which was initially published in 2010 and updated in 2017, really trying to put a stop into lots and lots of constipation being put through to surgeons to perform a rectal biopsy to prevent Hirschsprung disease. And what it says is very specific. It says do not perform a rectal biopsy unless you have one of the 5 presentations. Either you have delayed passage in recovery more than 48 hours, or constipation in the first few weeks of life. You have chronic distension with vomiting, family history of Hirschsprung, or altering growth in the presence of the above. And there's a link for those who are interested. But the problem with this is it's slightly incomplete. So our group felt that it should really include not just a NICE guideline, but perhaps neonatal intestinal obstructions as a previous presentations for someone who comes to you with constipations, or those with genetic predispositions, not only family history, but more commonly things like Down syndrome and the rest of the syndromes that you are fairly familiar with, which are associated with Hirschsprung's. So if you group all these features, you can call them red flags. And some of the consideration you should take before performing a rectal biopsy, certainly I feel that's important, is that there are a large number of constipations children out there. And as surgeons, we have concerns about missing Hirschsprung's as a diagnosis. So we err on the side of wanting to do a rectal biopsy. But we also know that all the red flags symptoms were not specific to Hirschsprung disease. and there's procedural related morbidity involved. So how do we get the threshold right for doing a rectal biopsy for our patients under these circumstances? So I just wanted to talk about a study that we did less than a year ago, looking at incidence of non-Hirschsprung biopsy, basically saying that if we put someone through the biopsy process, who will turn out to have a negative result, and how many of them. And I also want to talk about the predictability of non-Hirschsprung biopsies. Are the red flags alone enough, as in absent of red flags, sorry, or can we use something in addition to that, such as children older, over 6 months of age, in addition to the absence of red flags? Would that be enough to predict someone does not have Hirschsprung, and therefore we don't need to do that many rectal biopsies? So over a 4-year period, we retrospectively look at our data of patients who underwent rectal biopsies. 187 children, and some needed more than one biopsies, and 197 were included. So there were 84 suction rectal biopsy and 113 open rectal biopsy. We've excluded those who had post pull-through, that we wanted to check whether persistent symptoms were due to transitional pull-through or aganglionic pull-through, and we excluded those. And this is a brief overview of the results. So having excluded the group who are post pull-through, what you can see is that there are patients who had conclusive biopsy in one go, and others who are inconclusive. Every single one needed a repeat biopsy to determine whether they were Hirschsprung or non-Hirschsprung diagnosis. And we found that our negative biopsy rate was 78%, which is 22% positive pickup rates when we try and did biopsies on children that we suspected having Hirschsprungs. So this is slightly better than the historical data of 12% from Leeds and Southampton. And we then look at these two cohorts, the non-Hirschsprung versus the Hirschsprung groups. It is quite apparent and simple to understand that those who do not have red flags, those who are older with a median age of 22 months, but greater than 6 months of age, and those who are female, and those who undertake open rectal biopsy were more likely to be non-Hirschsprung disease. I just draw your attention to the bit of absent red flags, where in the absence of red flags, 7 patients still had Hirschsprung disease. And therefore, we look at whether or not age has any impact with regards to, red flags. And what you see in the red circles are what we expect to be the case. If you're very young and you have red flags, you're more likely to get Hirschsprung disease. That's true. But if you are very old or greater than 6 months and you have no red flags, you're more likely to get a non-Hirschsprung disease. That's clear. But these 7 patients who were having no red flags, presented late, understandably, had Hirschsprung disease. And I've listed them down here. You might recognize some of these presentations in your own practice. But what they are these patients are over 6 months, and they presented quite late. Some needed manual evac, and others just couldn't wean off their laxative. Some had faltering growth. Some referred quite old, 4 years and 6 years. One of these patients needed a repeat, so there were 6 patients, but 7 biopsies done. So on and so forth. And there was a UTI as well, who were under the urologist with a history of intractable constipations that we finally wanted to do a rectal biopsy for. So as you can see, all of them needed an open rectal biopsy because they were in the older groups. And one among these patients who were Hirschsprung disease, who had no red flags, was a female. So what can we make out of this? Well, I'll come to that shortly after, but I wanted to draw your attention to another point, which is if you look at how the patients who had no Hirschsprung disease, 63% of them ended up with open rectal biopsy. So that's a big number. That means 2/3 of our patients that we subject to a rectal biopsy, open rectal biopsy, had not actually had Hirschsprungs, and they have already gone through a general anesthesia. So it is a morbidity study in its own right. And if you do a univariate regression analysis and multivariate regression analysis, we picked up that should we correct for age and sex, the absent red flags is associated with 5 times more likely negative biopsy. So in conclusion, what we got from our study was that the rectal biopsy pickup rate was 22%. That does mean that 78% had non-Hirschsprung biopsy. But quite importantly, 2/3 of these actually undertook an open rectal biopsy. A red flags was clinically relevant for risk stratifications because we've demonstrated that, but sensitivity wasn't that good and specificity was reasonable, but certainly not enough to exclude Hirschsprungs. So an absent red flags in older children still carry 9% chance of being Hirschsprungs. And if you have absent red flags and being a girl, very low chance, but it's not 0 of having Hirschsprung disease. So red flags is useful for risk stratification, but it does not really exclude Hirschsprung disease and is independent of age. So age doesn't really matter, contrary to our initial hypothesis that it could potentially be beneficial. So I just want to stop here and just ask you to think about why this is important. Because I think we've demonstrated that we've done a lot of biopsies in response to our colleagues referring patients who have constipation. But actually, that process does carry morbidity and it's probably not very efficient use of our resources. So I thought that there are 3 points that are relevant that I want to bring up in our discussions. Should I carry on, Naeem?
Yes, please.
Right. So the first point I want to talk about is that what is the implication of a late diagnosis of Hirschsprung disease? Because surely, if if we miss the Hirschsprung diagnosis early on in life and kind of diagnose it sometime later, does it really matter? Well, our study, which was presented in BAPS last year, actually over a 20 years period, we had a significant number of patients that presented late. And we found that if you have a presentation over 3 years of age, then the late diagnosis was actually associated with increased morbidity. Not only you got higher stoma rates, but following pull-through, there's major complication is greater. And the more likelihood of having a redo pull-through, probably because the colon is a bit more dilated and the blood supply is a bit more compromised when you do a pull-through. And many patients in terms of functions ended up requiring enema, more in the delay groups compared to the timely diagnosis groups. And persistent stoma was also increased. So we realized, therefore, as surgeons, that if we have a late diagnosis of Hirschsprung disease, it's not good for our patients. And we talk a little bit about age, but I just wanted to point out here why it is slightly relevant, because as we say, older children greater than 6 months actually accounted for more than half of all the patients that we did a rectal biopsy in our 4-year period. But only 12% of this group had actually a Hirschsprung disease. So clearly, we're not doing this well. And older children required an open rectal biopsy under general anesthesia. So it's not without its own problems. Although I must say, my colleagues and myself rarely find that this results in any major complications as a result of the GA, but it's nonetheless a general anesthetic. It does take up time and resources. And therefore, risk stratification, when you think about it, is only particularly relevant for older children and not that relevant for babies where you can do a suction rectal biopsy on the bedside. So the question is, can we therefore screen these patients, the older group of patients, for the need for open rectal biopsy? And this comes on to my third point, which is, do we have an alternative tool? And from my humble opinions, I think there are three ways potentially you can change the current state of play. One is punch biopsy, another one is contrast enema, and thirdly, potentially endorectal mammography. Because this may offer us an alternative to look into. I'll be really grateful for your thoughts and your experience in any of these. But just to talk about punch biopsy first, one of my colleagues, Richard England, actually does this, but this is described quite a while back, I think in 1993, but it was published again by the Japanese Yoshimaru with 957 patients over 30 years, where everybody undertook punch biopsy. And you can see they call this basically a sigmoidoscopy biopsy forceps in our terms. And what it talks about is that you can use a blood bottle and drill a hole about 6 millimeter, and using that hole to then push against the mucosa of the baby's rectum or your child's rectum. And if you mark 3 centimeter, 1, 2, and 3, for example, you can determine at the level above dentate line where you want to take a biopsy from. And with this sort of approach, it was impressive to see that the inconclusive biopsy rate was only 4%, which means 96% of the time this gives you a really good biopsy. And only 0.1% of the patients, which is actually one in the cohort of 950 actually, who was a patient with liver disease that actually had bleeding. And that is still a very, very good outcome, I thought. But the important thing about this is that the Japanese was able to do it in outpatients and sometimes needing sedation if the child was a bit anxious, but no general anesthetic. And you wonder, whether we could practice this. I must say that I'm slightly skeptical about our ability to achieve this in the Western world. I think our children are used to, or our parents perhaps are more used to children not suffering. Not that in any part of the world parents are able to bear with that, but I think there is a pressure from clinician side that feels that when children are old enough to remember the trauma of a procedure, we generally tend not to subject them to a procedure that is perceived to be uncomfortable, like this. So although punch biopsy may be helpful in some parts of the world, it may be difficult to apply in the UK. Another quite commonly practiced investigations in many parts of the world, but not so much in the UK, is contrast enema. There are many papers which demonstrated the usefulness of contrast enema. And I want to draw your attention to one of them, which is from Dr. Levitt's group when he was doing Buffalo in New York. Basically, quite a nice study looking at contrast enema, of course, taking into account of symptoms. And if you have the symptoms, one of these three, plus the use of contrast enema to demonstrate the transition zone, or another term of rectal sigmoid inversions, you may be able to, well, the group certainly believe that it has got a role in avoiding significant proportions of patients undergoing rectal biopsy. So this is how the study was done, and 50 Hirschsprungs and 50 idiopathic constipation children were compared. At least one symptoms presence of all these four features, or all these three features, sorry, you'll be able to pick up Hirschsprung disease 98%, but 60% of idiopathic constipation will still have one of these symptoms. But if you then combine it with contrast, i.e. one of the four features present, you 100% picked up the Hirschsprungs, but still you may pick up 64% idiopathic constipations. In other words, you would not miss Hirschsprung disease if you use all these features together. And in other words, if you do not have any of these four features, delayed passage in meconium, abdominal distension, vomiting, and a normal contrast, i.e., then 36% of idiopathic constipation can be excluded and avoiding a rectal biopsy. So it seems very elegant and well described and really nice paper to read, but I'm still having my doubts, because although if you look at some recent papers in, the first paper from Germany, sensitivity of contrast enema 74% and specificity 95%. And obviously these patients went to have a contrast enema because they have got some symptoms of concern. And also if you look at a Pakistan paper, the sensitivity and specificity was very comparable, pretty good, but not really good enough, even though if you take into consideration and delay evacuations of 24 hours. So I think it then makes me feel that it's important to address anorectal manometry, because this is kind of the new kid on the block, but it's not that new. It's been used for at least over a decade, if not 2 decades, by some specific units who have the skills to do this. And essentially it is a test to demonstrate the presence or absence of rectal anal inhibitory reflex. And you do it by putting a balloon into the rectum, inflate the balloon, and basically at different time points, typically in these days of age with the child awake, with the help of play specialists. And this is how anorectal manometry is able to exclude Hirschsprung disease. And this is a slide I borrowed from Dr. Mark Scott from the Royal London Hospital. And with a good resting tone, if you insert your probes into the rectum, and once you inflate the balloon, you should see that the anal tone should decrease, demonstrating a positive rectal anal inhibitory reflex, which is normal. And in the presence of this, one could say that there isn't evidence of Hirschsprung disease because the anus is able to relax. And this is a chapter on rare that was published by Stuart Cleave's groups, and basically showing exactly the same things in high resolution anorectal manometry, where red demonstrates quite a high pressure, certainly purple even higher pressure. So if you inflate the balloons, and basically what you see is down in the anal canal, there's a drop in the pressure, but it will recover. And traditionally, we accept a drop of more than 25% from the baseline is enough to tell us that there is a presence of rare, and therefore excludes Hirschsprung disease. Now the question is, how good is this test? Well, first of all, let's look at what NICE guideline says in 2010. It's very specifically telling us do not use anorectal manometry to exclude Hirschsprungs in children with chronic constipations. Very specific, and we all abide by that. But if you look at the evidence that's led to these recommendations, and for those who are not clear, NICE is National Institute of Clinical Excellence. It is a UK health body to determine which treatment is most cost effective. So if you look at the paper leading to that recommendations, which is a systematic review published by Mark van Inger's group from the Netherlands, it is interesting read to see that anorectal manometry fares slightly less well than suction rectal biopsy, but significantly better than contrast enema. So I think it is clear that if we have to choose an alternative test, I would choose anorectal manometry over contrast enema. And well, the question is it good enough? Is it good enough? Are we still likely going to miss Hirschsprung disease if we just use this modality? And I was really quite pleased to see this paper came out 2 years ago by Paul Brown's groups, again in the Netherlands, looking at anorectal manometry that can reduce the number of rectal biopsies. So basically over 100 patients, they've prospectively done manometry and rectal biopsy for their patients and trying to see whether it matches the outcome. And basically the study was showing that if you do that manometry correctly, your negative predictive value is 100%. So what it is saying, in other words, is if you do an anorectal manometry correctly, you should be able to not miss a Hirschsprung disease. So, well, there seems to be evidence to support anorectal manometry is a good screening tool to exclude Hirschsprung disease. And I think NICE guideline is a little bit behind on this, but we have a recent paper this year published in JBGN, I think, on Busbergan groups, basically looking at whether there's a role of anorectal manometry in children with differentiation disorder. And the first indications of using anorectal manometry in this paper is to exclude Hirschsprung disease. And Busbergan is a British Society of Paediatric and Gastroenterology and Hepatology, and nutrition, sorry. So that's the group that represents our gastroenterology colleagues. So it is interesting to see how things has evolved over time, and it may be that one day NICE may revise its recommendations, but until then, it is still something that we have to think very carefully before embarking on. But the important thing about this paper is not just that, but more so because it gives you normal value. Because in the past, all the normal values for the pressure measurements in anorectal manometry was based on adults. But in this instance, this paper is the first paper that actually gives a standardized normal value that you can refer to and compare against. And one thing is interesting about anorectal manometry is that it helps with not just excluding Hirschsprungs, but it also has other benefits in children with constipations, because you can pick up things like internal anal sphincter achalasia or pelvic floor dyssynergia. So many children have big withholding behaviors. Many of these we would just treat with Botox provisionally, but it'd be good to know. It'd be good to know, wouldn't it? Of course, one can argue that if you end up giving Botox, you're going to go under general anesthetic anyway, and you're going to do a rectal biopsy anyway. So is there any point? I argue that there is a point, because if you don't pick up any of these, the children actually end up not having a general anesthetic, and that's still a big proportions. But manometry is a specific skill that one has to learn, and it is time consuming to do, and you need a dedicated team, particularly the place specialist and a physiologist. So I think although it is a viable option, it may not be very viable and immediately available. So I just wanted to take this opportunity to sort of share with you my thoughts and some of the findings we've come to, but I'm not sure whether you would agree with a logical pathway that looks a bit like this. This would be my last slide. Basically, I think that if you have suspected Hirschsprung disease, and if you're under 6 months, where you have a 35% positive biopsy rate based on our data, I think you should really go ahead and do a suction rectal biopsy. Because if you wait long enough and it persists to have problems, then you will find that you may end up needing to do more. So if you are older than 6 months with red flags, you have a 21% chance of positive biopsy. Whereas if you do not have a red flag, you have a 9% chance of a positive biopsy, which makes sense. But I think personally, because the chance of positive picked up is still relatively low, perhaps this group should be subject to anorectal manometry, and I'm putting a question mark there. It's not a definitive one. And if only rare is absent or inconclusive, that one is subject to an open rectal biopsy. And that's my thought. And I just want to say Sukriya. Thank you very much for having me today in your busy Saturday evening. And this is my beautiful hospital in Norwich, and you're very welcome to pay us a visit. And I'll be happy to hear your thoughts and have any discussions with you guys. Thank you very much.
Very well presented, Yew-Wei. Well done. You have comprehensively detailed the use of various modalities to diagnose. I know this is a very topical issue for a lot of us. I think you have given a very good scientific background around your conclusion. Can I take this opportunity to say some of my personal experiences over the years? And obviously, I do not deny that what you are saying is looking like the future to me. And I do not deny that there is certainly a role for anorectal manometry. But you have rightly mentioned that it requires special skills. It requires a team, it requires investments by the hospital and the trust. And at the end of the day, there may be some possibilities that it may not still avoid certain unnecessary biopsies under GA. I think in terms of the red flag, what you have mentioned, before 6 months, there is no controversy at all. The things remain debatable is what we do after 6 months. Is that right, Yew-Wei?
I agree. Yeah.
And that's the group where it becomes a bit controversial. Having said so, that till we can match the sensitivity and specificity of anorectal manometry to what we have with the rectal biopsy as of today, we will always have a struggle in making the right decision. And talking about morbidity of the GA also is a little bit relative in terms of where it is being performed and whether it is being supported by the pediatric anesthetist or not. In the West, there are both pros and cons again, that if we go with contrast study and anorectal manometry, it is also a very inconvenient procedure. It is not that straightforward. We say that, but to do that in a 6 months beyond age group could become challenging how to manage the child. Having said so, I would accept that I do not personally have a great experience with anorectal manometry, but I certainly see what happens in our urodynamics rooms when we get children for other urodynamic studies, etc. So a balance is required, and certainly the future is looking like that we'll get better and better and more efficient with our anorectal manometries. And certainly there may be a group where we'll be able to avoid some unnecessary biopsy. We have become very restrictive over the years as well. We used to do quite more than what we do today. I can tell you that. And you rightly said that most of them turns out to be a negative. How I have taken personally the use of rectal biopsy is is by making, I obviously have done most of the time, if I'm forced to go ahead and do an evacuation, I generally have made it as part of that procedure, that if I'm doing a good manual evacuation, a good anal stretch, and then a biopsy, what it has achieved over the years is a conclusive ruling out or ruling in of Hirschsprung. I have picked up only 2 Hirschsprungs, but I must have done more than 100 of these. But what I sell it to the parents is I'm not doing it for a rectal biopsy per se, but as a combination procedure. And what I also don't sell to them that my good anal stretch is going to make a big change, but it does make some definite change in a good percentage of people who get going after we have, one is we have ruled out Hirschsprungs, so we can convince the parents that this is not something mechanical or functional, but which can be supported with a more aggressive bowel management program. And that takes over the patient towards the right course. So I would say that I think you have done a very, very thorough analysis, and I must commend you for this thing. But I just wanted to add on these comments. So thank you for that. I'll see what our colleagues from Pakistan says about this, because they have a very different population, and the things may be quite different, and how they would think about this. Thank you.
Thanks, Mr. Minocha. For those of you who are not familiar, I'm sure you are, Mr. Minocha is my chief of pediatric surgery in Norwich. And I completely agree with all the things that Mr. Minocha say. I just wanted to make it slightly clearer in the sense that when there are many reasons we bring children to theatre, and if we are in theatre, I completely agree that we should take the advantage of the patient being under GA to have a manual evacuations and then do an enema and do a rectal biopsy. May it be punch biopsy or open strip biopsy. But I also is a big proponent of an enema disimpaction. So many of my children ended up not needing to go under GA, and then the question is is the GA just to accommodate the rectal biopsy and at the same time we do the manual evac, or is that patient actually go for a manual evac and then we'll just do a rectal biopsy at the same time? And there is no doubt that it will influence one another, and I completely agree. Otherwise, most other things are very true. In current practice, we still need a definitive diagnosis. Rectal biopsy is the only way forwards for older children.
Can I make a comment? Can you hear me, Tan?
Yeah, is that?
I'm Iftikhar Jan.
Nice to meet you.
Nice to see you. Thank you so much for this wonderful presentation. Really, it's very impressive that you brought all these, collected all this data, and really it is really very impressive data. I'd like to, just add a few things. Number one, we have got a totally different population. A lot of children who bring with chronic constipation, even Hirschsprung's disease, they present very late. And therefore, they don't have the classical picture of Hirschsprung's disease, but a lot of them are malnourished with a large tummy. And they have got chronic constipation, but that is not detected in time. And therefore, there is significant delay. And in these children, our barium enema or gastrographin enema is the first line of action once they have excluded functional constipation. And that does help in many children. And actually, we are talking about a different population. In the neonates, of course, the role of enema is quite controversial. Actually, my concern is more about the rectal biopsies, which we do and how we stain them. People don't understand that section rectal biopsy may not pick up the ganglia in all the patients, and you have to do special staining for that. And only centers who have got, if they've got facilities for acetylcholine esterase or calretinine staining, they can help to say with definite diagnosis that it's a Hirschsprung or not, or Hirschsprung-like disorder or not. So that is another thing which is very important to understand. The third thing is I was in Kyushu University for a while in 1993, and they were doing anorectal manometry at that time, and I had some experience of that, and we find that it is a good technique, but it's a very, very what you can say committed procedure. So you have to have a very committed team to do it, who understands all the procedure and can take the time to do it. And I agree with Ashish, who has said that this is the same when you are doing urodynamics. So you need a very committed team to do that. Unfortunately, with the workload which we are working in Pakistan, there is a big issue. You are not talking about 5 or 10 patients in a clinic. You are talking about 100 patients in a clinic, which is a big number. And you have that when you have got somebody who is really committed. So we have to actually, I think what I'll suggest is, you have got presented very excellent ideas, and I'll suggest that my team in Pakistan, I'm in UAE, by the way, in Abu Dhabi, so they should have taking your lecture as a baseline. They should start working on it and make up their own guidelines, which are which will be very, very useful in our setup, and that will be really helpful. All the other guidelines, because the histopathology itself in most of the centers, only the full thickness rectal biopsy will be feasible, because they do only acetyl, the standard eosine stents, and not the, they don't do the special staining, and not all the centers, some of the centers may do. So I think that is what is important to understand. And thank you so much for, presenting such a nice presentation, and giving a very thoughtful discussion on the topic. Thank you.
Thanks, Dr. Jan. I think in your population, it is really, really challenging to do anorectal manometry. It is very time consuming, and you may not find that's particularly cost effective either. So yeah, I can understand, but I think if you have a late presenter and your contrast enema, in theory, should have probably a greater pickup rate, because you would have a very, very dilated sigmoid by the time they come to you, and they wouldn't have had rectal washout, for example. So yeah, I think in your setup, it really is a very appropriate, and I can't agree more. Our staining, generally, depending on which center you go to, if the specimen is sent fresh, we stain HNE plus acetylcholinesterase, and also looking for mucosa carotenoid if there's any diagnostic doubts. But if it's sent as a formalin, typically we'll only be able to get HNE. Yeah, so that's something that's maybe slightly different, or maybe not too different. Yeah, thank you for your comments.
Yew-Wei, there are some questions on the chat for you.
Oh,
can you?
I will be able to see them. Is Naeem able to see them?
I think there is one or two for you.
Naeem, do you mind reading that out?
Jamal, can you do that? Because I had just a
yes.
Yes.
Okay,
There's
I'll
this,
try to read that.
can you hear me?
Yes.
Okay, there is this question from Javeria Kamar. She's asking that you mentioned 2 patients that developed constipation at 1 and 2 years of age. Were they absolutely fine before that with no symptoms? And second question is that, what was the length of segment involved?
Very good questions. I don't know what the length of segment was involved, I must say. When we review the data, we just wanted to check whether it is a positive or negative for the purpose of this study. In terms of the patient who had Hirschsprung but presented late, one was actually a baby with pyloric stenosis that came to us earlier on in life, but did actually have constipation issue, but only on very low dose of laxative. But because they just couldn't take the laxative off when the child was a couple of years old, the child, was referred by our gastroenterologist for biopsy. More than two, actually. Quite a few patients presented late, but most of them had actually, in those group of 6 patients or 7 biopsies, that group of patients, most of them were over, the others were all over a year old, apart from the one with pyloric stenosis. So yeah, it is a bit unusual, isn't it? But that's what it is, and that's why they presented late in the first place.
I hope it answers the question. Okay.
What's the other questions, Dr. Jamal?
No, there are no questions actually. So Dr. Sajid has raised a hand. So I hope he has a question. Dr. Sajid? Dr. Arshad also has raised his hand. So if you have a question, you can unmute your mic and ask the question.
Thank you very much, Stan, for presenting and this topic of rectal biopsy. I have also gone through this frustration of doing rectal biopsies and then coming as negative for Hirschsprung disease. And I also, a few years back, searched the literature and came with similar red flags, age less than 6 months and symptoms starting in neonatal period and abdominal distension and failure to thrive. And I have modified my index suspicion for rectal biopsy, and now I do much less biopsy than what I used to do maybe 15 years back. I think what you are highlighting is, one is that to diagnose Hirschsprung disease of patients, of cohort of patients who present with constipation, my worry is that as the majority of these patients do not have Hirschsprung disease who present late with constipation, and as your numbers are also suggesting that 63% will not have Hirschsprung disease, and you mentioned the barium enema study from Pakistan that we have published last year in QRS. And we also found that barium enema may help to streamline few of those patients, but still there is a cohort of patients who we may not be able to diagnose. Your suggestion for anorectal manometry and other is also, I think, valuable for making a diagnosis of those patients who do not have a Hirschsprung disease, whether they have a sphincter achalasia, because their biopsy will be positive for ganglion cells and still they will have symptoms. And if we have an anorectal manometry, we can very conclusively diagnose anal canal achalasia and our ultra short segment Hirschsprung disease, and that can also be treated. That also highlights that we also need to develop more facilities along with anorectal manometry with the intestinal motility studies and all those to treat these constipated patients, because constipation is a big problem now in Pakistan also. In every day we see about 3-4 patients, children with severe constipation, and if you ask the mother, they are passing daily stool, but they present with abdominal pain, and you do the X-ray and you see a big feculomas seen in the X-rays, and then you put them on enemas and they become better and their pain settles down. And what I have seen is that after, in a selected patient who are not getting better with your aggressive management, when you do a rectal biopsy, you again empty the rectum, you do some stretching while you are doing the biopsy, and biopsy also releases the internal sphincter achalasia, and they become better for some time, 2-3 months. And then again, they come back with constipation. So these are my comments on this topic. Thank you very much for your talk.
Thanks, Dr. Asha. Do you guys use Botox by any chance?
I have a question. That if in a patient at Professor Hirschsprung saying usually 3 to 4 years of age, presenting with chronic constipation, and on X-rays and typically on the abdominal examination, he has huge lumps and bumps of fecal matter which is infected, and you do a rectal biopsy, and if it turns out to be positive for the ganglion cells, and how do you proceed, particularly in those patients? What schema do you follow?
So, Naeem, did I hear correctly that you've got a 3 to 4 year old who had a rectal biopsy is ganglionic, so normal? How do you proceed? Yeah. So interesting questions, and in the sense, I think many people will do different things. So personally, I tend to have a high threshold to, if they don't have red flags, then they don't get a rectal biopsy. They get a very concentrated medical management under my care, and then only if they fail that they will undertake a rectal biopsy. But say if they do end up with rectal biopsy and it's normal, then at that sort of age, most of the children would have some sort of withholding behavior. So my approach would be to offer Botox in the absence of anorectal manometry, because most units are still not able to provide that. And the idea of Botox is just breaks the cycle of withholding behavior. No experience is about 50% success, but I tend to find that many of these chronic constipation children having relatively dilated rectum. So I would use stimulant such as Senna at a high dose, 2 milligrams per kilo. I usually go slightly lower than that to start with and build it up. Yeah. So that would be my overall general approach. I may not use Botox as much as some of my other colleagues, but the group at Evelina has got 80% success rate with their Botox, and I don't know whether that's because they use manometry quite regularly and they choose the right groups where the pressure is a bit higher, and then not the groups that are lower. So I suspect that may be selecting the right group of patients. So that also makes me wonder whether manometry has a role in selecting these patients.
Particularly go for the intestinal neural dysplasia or other Hirschsprung variants?
Yeah, I suppose if you can demonstrate the absence of rare in the presence of ganglion cells, then yes, then which is one of the reasons Botox is used in case that's the case. But where many centers do not have manometry, so yeah, so it'll be the treatment. If it's ISA, you give Botox. Yeah, so that would be the treatment of choice. Yeah.
What about the cyst mark studies or other colonic studies?
Yeah, which is one of the things that when I see children in manometry with constipation in clinic, they will receive a cyst marker, as our transit study we call it. And they, to be honest, the traditional way of talking about rectal evacuatory disorder versus pancolonic disease is somewhat arbitrary. But I think if it completely empties, then you are relatively reassured. But if it's not, then I think it gives parents the assurance that there is a significant problem here and do take the medicine. So yes, we do use that. Yeah.
Tan, can I ask you two more questions? One, how do you do bowel management for functional constipation? Because I think our team will be very much interested to understand that. And are we missing the intestinal neuronal dysplasia? Because about 10, 20 years back, it was one of the very hot topic. And now suddenly we don't see that much discussion on intestinal neuronal dysplasia. So is it, are we getting less patients, or is it just that we are diagnosing Hirschsprungs more in a proper way?
So yeah, I'll quickly answer the second question because I have very little experience with IND. It's all over the literature, and it's Professor Puri's has repeatedly been publishing in this area that has got the most experience. So I really can't easily answer that. So I don't have experience with that. I suspect it's again, you know, that you do not have the facility that the Irish group has, then you may not be able to undertake the same level of detailed investigations. So therefore, it doesn't get diagnosed as commonly, perhaps. I don't know. In terms of bowel management, everyone does it slightly differently. I pretty much follows Dr. Levitt's protocol, and functional constipations or not. But I think my experience with functional constipations is they generally do respond well to laxative if you manage to disimpact them. And you have to, so disimpaction is really the first step. And if they come with a rectal fecoloma, I personally use high enema with olive oil to soften the poo. And then about half an hour later, I give phosphate enema tailored to the patient's age. And that almost always successfully disimpact without necessarily needing to go for manual evacuations. And quite a few patients have in the past failed. Well, sorry, let me finish that. So once you've disimpacted, I would almost always have to reduce their mobicle, because with a dilated rectum, their sensation is very deficient. And to then soften the poo further makes the sensation even less. So I still keep on some mobicle to make the stool not too hard, but I usually then start Senna at a very high dose, as Dr. Levitt has taught. As a starting point, it was recommended at 2 milligrams per kilo. That's a very high dose for a lot of my patients. So I usually go cut back by about 2/3 of that, and then build it up. One important point is I do very close follow-up with my patients. All of them have my emails. If they have come to the point of needing bowel management, and they will have to send me a bowel diary weekly. And the first 4 weeks, I think, is the most important. And if you can adjust the dosage according to response, and making sure that they do not have soiling in between, no abdominal pain. And with Senna, you expect usually within 12 hours of taking the medicine, they will get a bowel opening. And if they don't do that, I typically will have a low threshold of increasing the dose further. And based on that response, I mostly will be able to get patients under control in terms of getting regular bowel opening and no soiling. For those who fail that process, then they will undertake bowel management through the enema route. And my starting point would be to do a rectal biopsy to rule out Hirschsprungs. So that's when I start, yeah. And once they go under GA, I also do an on-table contrast to determine the volume of rectal fluid required to achieve filling up the whole colon, in which case I can then use that as a guide to my enema regime. And all I then need to do is just titrate my stimulant dose. So Pena and Levitt's group has described using glycerin and oil, yeah, castor oil, I think. But we simply do not use that in the UK. Glycerin is not really licensed to use. So I typically use bisacodyl rectal enema, 2.74 milligram per mil, and starting at about 2 to 3 ml, and then I'll just cut back or increase. And I usually, in the past, have admitted the children for between 4 and 7 days and see that they do make a difference on a daily basis, radiologically and clinically. And then if they show that they're emptying well on the regime, they do not have soiling in between, then that regime is correct, and they go home with that regime for their enema. Yeah, and that few days staying in is important for them to learn how to use the device. We typically use Peristeen, Kufora, and Aquaflush. Those are the brands, but I don't think it really matters too much. And after that, patients will get a 1 month follow-up phone call, followed by 3 months follow-up face-to-face. And then I usually then pass on to the clinical nurse specialist. So that would be my previous hospital's regime. I think when you go to a new hospital, every hospital does it slightly differently. I will kind of work around that a bit. Yeah.
And just to add into it, you know, we found that a lot of patients who have got functional constipation, they do have anal fissure. And actually, that may be primary or secondary, but they do have most, if not all of them, but there is a significant number who will have it. So what we do is that we do advise them warm baths 3 times a day for 10 minutes. And then we use xylocaine jelly to the local area after the warm baths. And that does help to release the spasm which they have got due to anal fissure. So I think I agree with the rest of your things. And I think for our patients who are really chronically constipated, neglected, and who have got these secondary things, they have to be taken care at the same time.
Mm. Dr. Jan, do you just use xylocaine with no muscle relaxer, such as GTN or sort of calcium channel blockers?
You know, this is the one which is easily available in the pharmacy, and we just use it. It is very cheap, and our population is a very, very special population because we have to devise something which will everybody can afford, and we can make a standard treatment. So we just use xylocaine. I don't know whether it works or not because xylocaine doesn't get absorbed very quickly. We can't use Prelocaine here because of the risk of complication associated with Prelocaine. So we just use xylocaine, but I do find that it helps the patient to relax. But the warm baths definitely help a lot in relaxing the sphincters. There is no doubt about it. And with the warm baths, with the initial evacuation, and with the maintenance, with the laxatives, most of the even very bad ones, they will be, you know, they will respond. So you know, this is the more or less same what we use. The only thing which I'm scared is the use of stimulant laxatives. If you advise them, and our patients are not very educated, if they continue to use them for a long time, they will develop secondary complications like inertia of the intestine because these are stimulant. So I'll prefer to use what we call a lactulose, which is more you know, not a stimulant laxative. So I think that is what most of our people do in Pakistan. But we also have one very interesting some local remedies, and that is Ispagol. It's a natural product. It's a bulk producing product, and it will absorb water and not get absorbed. And if used in proper amount, it will help many children in relieving their constipation. So I think there is we have to adapt according to our own circumstances. And but thank you so much for this very nice demo, you know, for explaining this in detail about bowel management.
Right, thank you. So really enjoy listening to the use of xylocaine and warm bath. I will use that as my first line treatment as well, in which case I think it's worth trying and it makes sense.
Can I just make a little comment on this?
Yeah.
Yew-Wei?
Yeah.
What I'll say is that, yes, one thing is that since we have got the what we call disimpaction regime, the need for manual evacuation has really reduced a lot. And I would sort of follow the same thing, that we'll start with a disinfection regime, and along with enemas, of 10, you don't need to go for any sort of surgical manual evacuation. In terms of the management of the fissure, I'm a big fan of just using sitz baths and Vaseline, which effectively works the same way. I'm slightly worried with xylocaine, because if somebody has used xylocaine on an open wound, before it starts working and its analgesic effect, actually xylocaine lubricants are very irritant. So some of the children, they actually go into more spasms with it. But it could be a different experience with different people. But say sitz bath with some sort of just an application of Vaseline jelly relaxes them. And that's what I found useful. So I just wanted to share that with all of you. Comment about IND. And as you rightly said, that there was a lot of literature from Ireland, but then over the years, it has sort of, the interest has been subsided or whatever. But I think it is a subset of functional constipation. And eventually, it needs management according to its severity. And it's difficult, and it's still not very well defined. And certainly in UK, we haven't gone into looking at it in a more detailed way. So we may be missing some of these subcategories. Thank you.
We have a question. What kind of rectal washes you use for patients who present with enterocolitis?
Enterocolitis for Hirschsprungs?
Yeah.
Just normal saline. Yeah. So if so when they need washout and when they come to hospital, that's what most of us would use, normal saline. And many units will use a rough guide of 20 ml per kilo. But I personally will obviously bear that in mind, but I also would wash until clear for enterocolitis. Do people use something with antibiotics or anything else?
Have you any experience of use of vancomycin enema in case of enterocolitis, Hirschsprung related?
No, I haven't, but I can imagine it may potentially be helpful. Is that your experience, Professor Salim?
We are practicing here in Children's Hospital Lahore, and we have a good result with the vancomycin giving in enema.
What's the dose?
Our cases usually when they present, they are very in advanced stage. They have a much advanced Hirschsprung related enterocolitis, and we actually started this vancomycin enema, and we have a good result with this.
Excellent.
But one question, I do agree with Ashish and Iftikhar. Our population is somewhat different, and we have a limited facilities, and we actually are left in majority of the cases with 90% of the cases with open rectal biopsy. Suction rectal biopsy, although it is a very old technique, and still this is a availability of stain, stain is still a challenge in Pakistan, and it is practiced in only few centers. Manometry is available in few centers, just in Karachi and Lahore, but not widely practiced, and usually done by gastroenterologists, and still the results not dependable. Still, we are widely practicing open rectal biopsy, which is done by eosine, hematoxylin eosine stain. And majority of the pediatric surgeons, they believe on, they depend upon this. I do agree with you. We should move forward in case of manometry, and we can rule out so many cases of with the help of manometry. But my question, advancing the question of Iftikhar Jan, Hirschsprung related disorders like neuronal colonic dysplasia, immaturity of ganglia, hypoganglionosis, as once upon a very widely narrated by Prem Puri. What is your, can you further share your experience about this? Will we miss on manometry these cases?
The bottom line is, I think my experience would only be limited to, anal sphincter achalasia and Hirschsprungs. The hypoganglionosis IND is not something that I think most of our labs would, regularly report. And certainly, in the last 10 years, I have certainly not come across anyone with those alternative diagnoses. So I think if anything at all, I might have to hear your experience about this.
Just only, I have already highlighted, we are very limited in availability of stains. We are already left with hematoxylin eosine stain, and depending upon full thickness rectal biopsy in Pakistan. We have not even availability of histology estrase staining in Pakistan in majority of the cases.
Right. Yeah, same here. It's not something that I come across regularly. Anyone who has more experience, I'll be very pleased to hear your experience.
Only when, in Japan, what they were doing is patients who have got a positive, who have a presence of ganglia cells with a positive acetylcholine esterase. So these were the patients who probably had abnormal ganglia, and these were dysgenetic ganglia. And these were the ones who were further classified into intestinal and neuronal dysplasias and hypoganglianosis and megaganglianosis. All these different terminologies were given. But what I feel is that as we have progressed, our diagnostic rate for Hirschsprung disease has improved, and our staining capabilities and all the other things have improved. Therefore, we are making more confident diagnosis of Hirschsprung's disease, and therefore the number which we are getting for who are not Hirschsprung's disease is less, or where there is a doubt is less. I think that is one of the factors. The other thing is centers who are only relying on only one biopsy, for example, H&E staining for ganglia cells only, and not doing special staining, they will miss some of these patients, because some of the patients may have the ganglia cell, but at the same time, they may be calcitonin negative, or they may be positive for acetylcholine esterase. So these are the patients who need further investigation for Hirschsprung-like disorders and similar intestinal neuronal dysplasia. So I think we need to look more into it and try to get staining, at least 2 staining, at least for all these patients, acetylcholine esterase and the rectal stendal H&E staining.
Yeah, from Dr. Puri's previous lectures, the groups will require, once you rule out Hirschsprung, then you suspect variant Hirschsprung disease, they would do a full thickness biopsy, and as you say, all the specialized staining will have to be used, including H&E, all the histochemistry, immunohistochemistries, silver staining, and they also do electron microscopy, if I remember correctly. So those are the things that not many units has the facility to achieve. I think is the reality. So yes, we must be missing some, as Mr. Minocha has mentioned.
Okay, thank you, Yew-Wei. So do you have any other question from the group?
Before everybody leaves, can I just thank you to my friends? I see a lot of friends which I have met after a long time. And also convey my best wishes from the International Affairs Committee of BAPS, and I hope that we can continue with these deliberations more regularly with your association in future. I really enjoyed, and I must say I'm proud that Yew-Wei-TAN has joined our team, and he's a very enthusiastic and a very capable young surgeon, and I'm sure he will fly the flag of pediatric surgery high, not only in Norwich or UK, but internationally. And we can have more collaboration with Pakistan as well. Thank you, everybody. And thank you again, Yew-Wei, for your brilliant and excellent deliberations. Thank you.
Appreciate your kind words, Mr. Minocha.
Okay, thank you so much. And at the end, I would like to invite Professor Iftikhar Jan to say a few words on the behalf of Association of the Pediatric Surgeons of Pakistan.
Thank you, Dr. Chen. I think I don't have any words to thank you. Really, I enjoyed very thoroughly your presentation. It was really very elaborate, very informative. And I'm sure all of our youngsters, they were keenly waiting, and this shows all are present from the start till now. So this means they really enjoyed your meeting. Thank you so much. We look forward to see you again on this forum with some other presentations. And also, you know, feel whenever you have got any meeting or any conference which you think that will help our youngsters and our surgeons, please do involve them. Our teams are very receptive, and we have got a very wonderful pediatric surgery family which joins meeting actually more or less every week or 2 weeks. So thanks a lot, and really appreciate your efforts and your hard work actually. And thank you so much. I also wish to thank Ashish, because Ashish is one of our old friends. And thank you so much, Ashish. I was really looking forward to see you sometime, and it was a pleasure to see you here today. And really, you know, this collaboration is really very helpful. And we are so glad that because of you guys present, it makes it really very informative. Our people cannot travel abroad, you know, it's not easy. And now nobody can travel actually. So these meetings and these online meetings are really helping improving in our system. And if you attend some of our meeting, you'll be surprised to know the amount of work these young people are doing. And our young team is really very impressive. They have now, we have got now pediatric surgical center all over the country, in most of the cities. Before it was not possible. And even in the most remote area, actually in Sawat last year, they opened a center, and just few months back, it got recognized for training in pediatrics. So you just imagine that the remotest of the remote area has got so much facilities that it got, you know, accepted for training. So I think you guys are doing a great job, and it's a great job not for you actually, it's a great job for the patients which we are treating. The message which they will take today, it will go a long way in treating their patients. And these young surgeons, they take them very positively, and I hope that it's going to help all of them. And I also inform you that we are having our annual congress in February next year. And I think Professor Salim will send some official invitation, and it will be a pleasure if you can join us and do some presentations, and you can send some lecture. And Ashish, please do join us in the annual.
Sure, always.
Yeah.
I would love to. Just one more thing, that Norwich actually runs an international teaching training program. And if you are interested, we can send a link of that to you as well.
That will be great. That will be really wonderful. And I'll ask our team, youngster team, to coordinate it with you, so that they can have a regular meeting.
And this program is directed towards the postgraduate examination, especially FRCS training as well.
Wow, wonderful. So guys, now ball is in your court, so you can start working on that. And thank you so much. It was a pleasure again to see you all. And, you know, also congratulations to all the youngsters who joined and stayed with us till the end. Thanks, Naeem, and thanks, Professor Salim, and all the organizers, Nabila from Pakistan team. Thank you so much for, and you know, our president, Professor Anayat, he also conveyed his regards, and thanks to all the participants, and especially to Dr. Tan and Ashish. Please accept his heartiest thanks from his side. Thank you so much.
Thank you. I've learned a lot from you. Thank you so much, everybody, for joining us and allowing me to take part and learn.
Thank you. Good night.
See you all.
Have a nice evening.
Nice evening.
Shukriya.